You're listening to Mistreated. I'm Nam Kiwanuka. In Ontario, family doctors are the gateway to the healthcare system, including providing a referral for a specialist. If you're one of the nearly 2 million Ontarians without a family doctor and need to see a specialist, say a gynecologist, it can be incredibly challenging to get the care you need. Even with a referral, wait times for gynecology are long, and if you need surgery, they can be even longer. A February 2025 report from the Women's Health Coalition of Ontario indicates that wait times for gynecological care are, quote, unacceptably long, with some tertiary centers having wait lists of 800 to 1,500 patients, and that the, quote, most complex cases face delays of 2 to 3 years for surgery, leading to serious health consequences and significantly reduced quality of life. According to Medscape, an online publication for physicians and healthcare professionals, major delays occur at every point in the patient journey, from imaging and diagnosis to surgery. Before the COVID-19 pandemic began, the average period from diagnosis to treatment in Ottawa was 7 to 10 years. Since then, wait times have increased by 2 years, and some patients report a 12-year delay for initial assessment. Women with complex cases can wait 2 to 3 years for surgery. Often the condition is so far advanced by that time that it requires more serious intervention. Untreated endometriosis can lead to kidney death and bowel obstruction, and fibroids can grow into 2 and 3 pound tumors, thus resulting in massive bleeding and infertility. And that reporting is from July 2025. Today we're speaking with Dr. Zainab Abdurrahman, the president of the Ontario Medical Association. We're talking to her about the work the OMA does in advocating for Ontarians and for physicians and the crisis we're seeing in public health care in Ontario. She joins me now. Zainab Abdurrahman, welcome to the podcast.
Thank you so much for having me.
Can you tell everybody what you do?
So my name is Zainab Abdurrahman. I'm an allergist and clinical immunologist. I'm also certified as a pediatrician, and currently I'm also the president of the Ontario Medical Association.
Well, yes, you are Ontario Medical Association's 144th president. Yes. What is the OMA and what does it do?
So the Ontario Medical Association is the representative body of all the doctors of Ontario. So we represent all the doctors in practice, retired, and those also in training. Mm-hmm. So we advocate for our members as well as for the healthcare system, because that's where we work and live and function. Mm-hmm. So we advocate in terms of, wellness for our physician and also wellness for the healthcare system and for our patients, so that they can navigate the healthcare system in the easiest, simplest way possible.
When you said that you were the president, I was like, because you're very humble, but when you became president, you also made history as the OMA's first Black woman president.
That's correct.
What does that mean to you?
For me, it means that others are going to now look over and say, you know what, I could be in that position too. It's really important to have representation, I think, at all levels of leadership. I think of just even for myself in my practice, day to day, like I see lots of little Black girls and they come in and they're a bit shocked and they'll say that their moms, they're like, she looks like me. And their mom's like, yeah, you could be her. You could be the doctor. And I hope now they'll look and say, I could be the doctor. I could be the president of the doctors. I could be anything really. Yeah. So for me, it means a lot. It means a lot for just, I think, our community at large.
I think some people might hear that and not fully understand the magnitude of that. Because if you're not used to seeing people that look like you in spaces of authority, mm-hmm. you might not be able to think that's something that I can do. And it's only now that a Black woman is in your position. We're also living at a time when there's a pushback on DEI, mm-hmm. and when Black communities, which I might also add, are not monolithic.
Yes.
Black communities are being pushed into the corners of political slogans, and you've made history. What has the experience been like for you so far?
It's been an eye-opening but very exciting experience. I do have the opportunity to be parts of lots of different conversations and to be at tables, which, traditionally we've not had even enough women, enough racialized women. And I think it's important to recognize that, when you are from, there's a lot of intersectionality for all of us. I'm Black, I'm a woman, I'm immigrant. There's a lot of different views that we bring to the table. And I think others who may not, you don't have to be the same as me for you to appreciate that I have an understanding of what it's like to be othered, what it's like to maybe not be considered. And I think it gives a lot of comfort to a lot of different groups. And so it's been one that I've really taken seriously. I take the fact that I am the first Black woman president, and I really take it every opportunity to really emphasize that I don't want to be the last one either. This is not something that should just happen once as a blip. The goal is to really open the doors so that we continue to see this diversity. We should be able to see anyone who is in this membership to be the president. That's what it means, to live in the society that we do. So I'm hoping that we'll have less and less of the first and onlys and more of the, yes, any of us can represent all of us.
I want to come back to that conversation in a little bit about, what you're doing in healthcare and the importance, because some conditions impact some groups in different ways. But I read an article about you that said that you grew up in a household where, quote, medicine was not just a profession, but a way of life. Why did you pursue a career in healthcare?
I really like people. I liked talking to people. My dad is now a retired pediatrician, and so I got to see what he did. And I really just loved that he got to speak to families all day. As a child, I also loved that there were always children in his office. But I really loved the thought of having a career in something where I got to be part of people's lives. I also really liked science, math. That part also drew me. I also had other family members who were also in kind of science-driven careers. One of my first cousins, she's a vet, although now, and then since then, she also now works more in like public health realm. But I remember even as a kid, going with her, and she would take me and say, come see, a cow being delivered. I mean, it definitely ruled out obstetrics and vet school for me, but it was really exciting to be there and to see. So I think that our families have always just kind of said, oh, if you're interested in something, go see it, think about it. There was no real limitations per se, and it was very much encouraged. And I worked in my dad's office as a teen, and I'd have all these families say, oh my gosh, your dad was there when I was having my baby, and it was so scary. And then he came around, he said, your baby's fine. As soon as, they're done with you, they're going to bring you to the NICU, you'll see the baby. And they talked about how comforting he was and how it was so nice to have this face, kind of peeking over to talk to them. And I just thought, wow, I want to be that for someone one day.
So from a young age, you understood the relationship between a doctor and their patients. Yeah. It's not just numbers, but it's very intimate.
It is. You get brought into really the private parts of people's lives sometimes it could be at the worst day for them, and you have that ability to bridge and to comfort them. And you have to consider many people may be meeting a physician for the very first time. So it's really nice that we're able to kind of touch someone and be there for them in that moment. So that really spoke to me.
I wonder then how you see the situation that's happening in this province right now. You know firsthand that the healthcare system in the province is strained. ERs in some jurisdictions are closed. There is a family doctor crisis. I've watched the news, and people would line up for hours in the dead of winter when new clinics open. Doctors are also struggling to be paid for their work. In your role, you act as an advocate for doctors, the residents of this province, and also medical students, correct?
That's correct.
How do you then prioritize the very different needs of those groups?
Yeah, there's a lot of definite moving parts, but I think some of the issues really go across, when we're talking about, wellness, really, because I often tell people it really comes down to wellness. All the work that I'm doing in terms of equity, even for physicians, it really comes to be that everyone deserves wellness.
What is that? What do you mean when you say wellness?
It means that, you deserve to be healthy when you're working, be in a healthy environment to work, healthy in terms of the powers that be should pay you appropriately for services rendered. You should know that you can handle all the amount of work. You should know the system is also absorbing its own work and that you don't have to take on more. So for me, it's really about that. And so showing that to the medical students so that they see that they have a space moving forward, that they've chosen the right path and they could choose any of the paths, and so that for me, it kind of all comes down to kind of wellness. I want all the doctors, all the residents, all the medical students to feel safe where they work and know that there is their career, their chosen career is still for them.
What about the residents in the province?
So when you say residents, I want to clarify, you mean
Ontarians, the people who have access to OHIP.
Sorry, when residents are also right. I know, that's what, I was like, wait,
oh my God, one of my favorite shows is called The Resident.
Yes, I was like, are we talking about the residents in training? Are we talking about the people of Ontario? I just want to be sure before I answer this question.
Oh my gosh, I'm so sorry.
Yes, no, that's
the
okay.
people that live in the province of Ontario, yeah.
Because that's who we're also really doing this for, because I know that if our doctors aren't able to sustain and survive in our healthcare system, what happens to our patients? You see so many physicians going, and they're like, I just can't go anymore. I've tried so hard. They've been fighting almost against the system to get care for their patients. And I know that if that person leaves early because they're burnt out, that actually, affects so many patients. We see so many people. So for the people of Ontario, by advocating for their doctors, it's advocating for the healthcare system. And who knows better about how hard it is to navigate the healthcare system than those who are seeing the patients who are having those difficulties, because we see the troubles and we see the results of not also being able to get through the system in a timely fashion. And we see that, unfortunately, it does affect different populations in different ways. So that is, to do the work, to advocate for doctors is to advocate for the people of Ontario.
It's become a thing for people to say that I'm lucky to have a family doctor. And living in a place like Ontario, one of the wealthiest jurisdictions in the world, it doesn't feel that we should be saying that.
No, absolutely, because there shouldn't be winners and losers, right? Because, if you're saying I'm lucky, that means that there's someone who's unlucky. There's someone who doesn't have. And it is unfortunate, because you're right. We're in the largest province. We're, quite significantly well funded, but we're still having this issues. It's also an issue that's reflected across the country. And I think there has been some lack of foresight in terms of looking at medicine, looking at planning in medicine. If you look back in the history, you'd be surprised if I told you in the 90s, they actually cut down medical school spots. The government in power decided to decrease those numbers.
Because the population wasn't big enough? Or
No, the population was, but it was, they felt that it wasn't, they had enough that they could do. But it's a lack of foresight and not thinking that each generation is going to be slightly different. We're going to have expansions in population. We're going to have immigration. We're going to have birth rates. There's so many, you have to forecast it. We spend so much time forecasting about a lot of different areas in terms of just, how Canada works. But I don't think there was enough of it spent looking at the population, but looking at it in terms of physicians and how physicians share this load and realizing that we need to actually have more. And the styles of care also change over time. And we're going to need more physicians in different areas and, opening up all the different, there's some specialties which are very small by default, but we still need more of them. Yes, we've had less, but for example, I'm an allergist. We don't actually have that many allergists in Canada. There's about 250 of us, maybe getting close to 300, but that's across Canada. And if you're in upstate New York, I think there's about 250 allergists there. So there's not quite enough. And you have to always consider that the population's increasing. We have increasing allergies. We have increasing aging populations. So we have to be forecasting and increasing to help support that. And physicians who have retired, who have been in practice for 40 years, they often have larger practices than perhaps newer physicians. It takes you time to feel comfortable, to set up, but also the population has become a lot more complicated and more complex. So certain patients just need more time now. So you're not going to see as large of the practices anymore. So you have to also factor that in. So it's the lack of factoring so many different factors that have kind of led us here.
Mistreated is a podcast on women's health, and we're hearing from a lot of women who are saying that they're waiting for a long time to see a gynecologist or even just a neurosurgeon. I will ask you that in a moment, but I wanted to just do a quick follow-up. Ontario's doctors and the province recently reached a new 4-year deal that concludes compensation increases for your members. That said, some doctors are finding it difficult to get paid due to Ontario's billing system. What is the ministry and the OMA proposing to do to fix that?
Well, we've been speaking from the OMA perspective, we've been speaking about this issue for quite a long time. And we brought it actually to the arbitration board in terms of our negotiations. And the arbitrator has said, which is great, it's in writing, it said that we must find ways to address this. And if it's still not resolved in the next few months, then we do go back to the arbitration board. We've come up with a lot of different solutions. Some of the issues can be for complicated surgeries. Just by putting in so many codes, that gets flagged and then it gets automatically rejected, asking you to manually show proof that you did do all of this complicated surgery. But the people who are reading it may actually not have clinical experience. So I don't know if you ever read an OR note, but they're really complicated, even for myself in the field, but not someone who does surgeries day to day. So we're asking for them to have people with clinical expertise being the first ones who are reviewing these notes to determine if it's appropriate. A flip side of that is, for example, any of our most vulnerable populations, if you're experiencing homelessness or mental health or addictions, it's really difficult to validate your health card because one of the things that's required to renew it is an address. Yeah. And so we know these people live in Ontario. We know they're eligible. We know they need care. And yet those bills will be continually rejected, but we know that they are eligible for it. So we're asking for them to bring back some of that good faith billing. As I said, I'm also certified as a pediatrician. My first 2 years, I did work in pediatrics. So when we would see newborns, once you have a baby, you have, I believe it's about, 14 to 30 days to get to that Service Ontario to get that temporary paper. Yeah. Exactly. But it's difficult. You are barely,
I had a C-section, so I was like, I'm not.
Exactly. Yeah. But then that gets rejected for those who provided the newborn care because they also process it on a monthly basis. So usually by the time it's submitted and processed, that temporary number has expired. Mm-hmm. And, sometimes we have it where, the babies don't survive. And then, OHIP will say to someone like myself, well, just call the family and have them go to Service Ontario and register.
The families are grieving.
And I say, I'm only going to call them to offer, words of support and to see if they want to talk, but I will not be sending them. And so it's kind of left to you to just absorb non-payment for that because no one in their right minds would go and bother a family at that time for something like this. You should know it's registered that they passed away, so it's in the same system. So why do we need to have them go there? We've already processed all of that through the hospital. All that information is known. So it's things like that, just extending any baby, giving them 90 days. That's what we're asking for because sometimes it's just, you're just busy. It's difficult. Like you said, after a C-section, there's a lot of things happening, adjusting, not sleeping. Give parents also a little bit of wiggle room, I think is also fair.
Right now, there's a lack of data around gynecology and the wait times for seeing a gynecologist. Women are leaving the province and the country to access care. What needs to be done to change this, to also prioritize gynecological care?
I think, firstly, when you have an issue, you have to actually look at it. You have to actually measure it. There's so much data that's being collected about time to, knee surgery, time to hip surgery, time to eye surgery. It's important that we also elevate some of these issues in terms of time to, I know we've talked a lot on your podcast about fibroids, and that is an issue that affects so many women. So why don't we look at time to fibroid surgery as one of the other ones, or just even time to access to gynecology, because unfortunately that is much longer than people often think it is, and sometimes it's very difficult to get people who do certain types of surgeries. So also looking at that. Often they'll say, we don't have the data supporting this. Well, if you're not measuring something, you also don't know about it. And I think it's a reflection of the equity issue. I think this came up also during peak pandemic times when we were trying to prove to show that, we were having disproportionate deaths and illnesses in Black people. And they said, well, do you really know that? And they said, well, you haven't been collecting race-based data, but we can tell you if you're looking at certain regions, we've seen this, and we've seen the postal codes, and if you don't look for something, you can't address an issue. And I think that's one of the things we need to have is more looking at access to issues that disproportionately affect women or only affect women. And we haven't had this light being shone on.
I think the pandemic shifted us in so many different ways, and doctors at the front line. I can't imagine the weight that you all felt over the past few years while I navigated my own health problems. I was really surprised to find out that we don't even track wait times for gynecology care. So if you don't track it, like you said, if you don't have the data, how can you change it? And it blows my mind that we don't track conditions that impact 50% of its population. How is that anything but bias?
It's not. It is bias, right? And that's, why I often tell people it's really important for us to change our leadership structures, because this is when you start to determine what you look at. If you're not thinking about it, if it's not discussed at the tables that determine what we're looking at, you're not going to have those views kind of coming down to the general person. And so, unfortunately, when tables have been predominant, a lot of the leadership tables in the past have been predominantly white and male. They have not been thinking or talking about specifically women's health issues, talking about things like fibroids, talking about, even menopause. I can tell you we're talking a lot more about menopause. I can tell you in medical school, I have very little education on menopause.
How much did you have?
I think there was a day or two where we talked about it briefly in the classes, and then on my obstetrics and gynecology rotation. We spent a bit of time on it, but that was because one of the people where I did my rotation, that was an interest of hers. And so she spent time speaking on it, and we had teaching sessions on it, but that's not necessarily built into the curriculum as well. So this is an issue. We also need to change how we're teaching about certain conditions, because, I would say as a family doctor, for people who are in family medicine, they are seeing this a lot. And so we need to also train people to be able to identify it, to be able to have conversations about it, to also talk about things that are okay to not be okay. Personally for myself, all the times of having heavy periods, then having cramps, everyone just said, that's just part of life. That's something that happens. And we should really have probably said,
that's not normal.
That's not normal. And we shouldn't have accepted this to be the norm, that it's just okay for half of the population to constantly be in pain. And, and the thing is, not everybody has that, but to just,
some people have
it. And just to say, this can just happen, and no further discussion.
I'm still stuck on a day or two. I'm just like, oh, what?
Yeah.
Oh my gosh. It explains a lot, because I think what's happening for a lot of women, you get frustrated because you go to your doctor, and as well-meaning as they can be, they don't have that information. So you go online and then you try to figure out what is wrong with me. I realized fibroids were serious from the information I read online. We've also heard from women on this podcast about them being denied access to out-of-province care. They've gone through all the steps, have the letters from the surgeon, have these very rare conditions that impact mostly women. And then they're through red tape. They are denied that care, and then their life is just a life of trying to advocate for themselves while the quality of care for their life just goes down. What is the OMA's position on helping these patients?
Our position is really to support support our patients, and we want there to be less red tape. This part, because a lot of times, like as you said, they have all the letters from their physicians. Their physicians are advocating for them. We know kind of what's available in our healthcare system, and often, yes, a lot of times within our healthcare system in Ontario, we can get care for a lot of aspects. But sometimes when we say we don't have this in the province, and you've provided all this information, it's so frustrating and you're helpless because you said, I've written the letter, and you continue to try. So really believe that you should listen to those in the healthcare system. If we've said this is not available in Ontario, we need care elsewhere, or we need to get either surgical care elsewhere or get certain medications. And when it's just not approved, it's so frustrating. And we really want there to be easier ways to navigate through some of these. And for sometimes they're rare conditions, but sometimes they're not so rare, but we just don't have access within. And we have to be able to navigate this in a fair fashion, because for some people, they'll say, I didn't even know you could continue to ask, or there were other ways to get around. And we have to be fair that some people have the means to just opt to do something privately elsewhere, and others do not. So those who have not are going to suffer more. And so we really need this to be something that can be easily navigated in a fair process where you understand the rules. Sometimes it feels like you don't know what the rules are to get something across.
Do you worry about the ripple effect that can create between patients and healthcare workers? Because I think from my own experience and from the people that I've spoken to, it creates this lack of trust. And then when something happens like around measles, you're like, well, I don't trust the doctor or the healthcare system because when I needed care, no one cared for me. Do you worry about like that because it just feels like it's creating a ripple effect into many different areas that impact all of us?
I do worry about that impact. I worry a lot about it because it's exactly what you said. Sometimes, when I can't get someone something that they really do need, they're so disappointed. They're like, if you can't do this, how have you tried hard enough? Or, it's seen as a failure, and you can't help but obviously look at you put everybody in that, the healthcare system, the physicians, the nurses, you kind of put everybody there. And it's really unfortunate because it's a failure of the system, but people still advocated for you and were in your corner. But you're right. At the same time, some people also have had difficulties with getting the buy-in sometimes from their physicians as well, because maybe they're not as versed on this. They don't recognize that certain groups are at more risk than others. And so that does lead to this kind of changing shifts with trust, so that when things like this happen, like the measles outbreak, when we did the work, the pandemic is just a great example because it's a great time when everyone was really focused, when we were talking about bringing vaccines to, the Black population, because we were seeing that disproportionate disease impact. A lot of people said, okay, let's go, let's mobilize. And we were like, whoa, whoa, whoa. How can you not think for a second that there might be some historical aspects that you can't just go barging in with this huge vaccine campaign and without recognizing some of the issues with trust there. So you also there has to be a level of humility with it to say, you know what, there were times when we did fail. And that's when we did the Black Scientist Task Force on vaccine equity for COVID, we went in focused on that. We said, let's talk about the times when the healthcare system specifically failed Black people. Let's be open about that. And that's why we all got together as Black people in different aspects of, myself, I did a lot of work on vaccine allergy. Other people did vaccine development. Other people did, a lot of different areas to kind of bring together and say, we're bringing here to talk about this because we realize there were previous wrongs. So you have to also be able to say, in the past, we have had some wrongs and address it with humility, but also with the knowledge. You have to also appreciate what has happened in the past.
Yeah, that's why I always had a problem with the term anti-vaxxer, because it just sounds like it's derogatory, because there are reasons some communities might be vaccine hesitant. And so I think language is very important. What should our provincial leaders be focused on right now with the bigger picture of what's happening in this province?
I think right now, looking across, we really need to focus on ensuring that we can get, I think, every Ontarian a family doctor. Why? Because that's where you build trust with these one-on-one relationships, where you get to know them over time so that you can have these conversations, where you can talk about if you're hesitant about any kind of a vaccine or any kinds of treatments. You need to be able to build trust. And it does happen in small conversations with someone that you have built, relationships with over time. So we do need to focus on that. We also need to focus on making sure there's enough of the consultant specialists in the pool so that when patients do need to see them, they're available. And we're not seeing this huge waits in our system. We need the healthcare system and the government to also provide to allow for this and to allow for this communication across the different people in the healthcare system. I think one of the things that would really help, I think, for all of us would be if we had better digital health infrastructure across the province so it's easier to move information. If someone needs to refer someone, for example, your family doctor refers to one person. If they're not available or that's not their field, they decline it. They have to find someone else. And you keep going. And there's no one place to go look at everybody and see what their different areas are of like hyper specialization. If we just had a system like a central referral pathway where your doctor just has to put in, this is the issue specifically, my patient is willing to travel 50, 100, 150 kilometers. Everyone has different, open to traveling so far, and saying, this is what I'm looking for, and let the system do that. And then let the doctor go back and spend time with their patients.
It's surprising that we don't have that yet. But then again, as a parent, I still have those yellow cards for vaccines where it's like, why isn't this in a system? You were talking before about data and the importance of collecting data. Recently, the Black Women's Institute for Health released the first of its kind, Canada's first national health survey of Black women and girls. The report is called Unheard Voices, and it looked at how Black women experience the healthcare system and how they're treated. Why do you think it's important to have reports like this?
It's important because in the end, we still need data, even though we have ample amounts of it seems like an obvious truth for so many. In the end, we still need to show this data and to provide it and for it to be available to all levels of government. Like I said, if you don't measure something, you can say, we didn't know it was a problem. Well, now you can't unknow this. So it's important for all this kind of information to get shared at every level because healthcare, yes, provincially provided, federal transfers, but in the end, every level of government does play a role here because when you look at health, there's many aspects more than just seeing your doctor, seeing the nurses, seeing all different kind of health providers. It actually, biggest determinant of health, housing. Biggest determinant of health is actually having that aspect of community. Our mental health, we require community, and that is a huge thing to think about. So we need social services to also hear about this. So we need data like this so that when we come out and we say, look at different populations, look at specifically Black women and girls in Canada, and look at how adversely affected they are by the healthcare system, by our social services. You cannot say, we didn't know. That's no longer acceptable. So this is so important for any advocacy moving forward and for it to continue to be done. So we've shown that you can do it, and so we hope it'll continue to be done.
It's been an absolute pleasure speaking to you, Zainab. It feels weird calling you by your first name. But is there anything that you'd like to add that I missed?
I think that I just want to say thank you to you. I think that so much of what you've been doing on this podcast is highlighting so many of the issues within the healthcare system. We still have disparities, especially when we look at gender. And then when you lay in intersectionality into that kind of becomes wider and wider. And so, this also provides a platform for a lot of this information to get out there. So thank you. You're also helping in terms of this. So
thank you so much. I hope these conversations can push forward policy for women.
Absolutely.
We appreciate your time. Thank you.
Thank you.
We reached out to Ontario's Ministry of Health for comment following our interview with Dr. Zainab Abdurrahman. Here is some of the response. Ontario's medical claims payment system, MCPS, efficiently processed more than 200 million claims annually. To be clear, over 99% of these claims are paid automatically, exactly as submitted, reflecting the system's productivity. Only a small fraction, 0.58%, of all claims are sent for manual review, and even among these, more than 95% are resolved within 30 days. More nuanced cases go to a medical advisor, a physician for final review. Outcomes include full payment, partial payment, or return to the provider, and physicians can appeal with additional information. It's ultimately disappointing that the OMA is choosing to focus on 0.58% of OHIP claims rather than highlighting the real progress we've made together to support physicians. Our thanks to the Ministry of Health Press Secretary for getting back to us, and to read the full response, we'll post in our metadata. This was Mistreated. Thanks for listening. You can follow our show wherever you get your podcasts so that you can get notified each time a new episode is available. We would love to hear your feedback. You can write me an email at mistreatedpodcast@tvo.org or reach out to me on my social channels. This week's episode was produced by Matthew O'Mara and me, edited by Colin Kish. Camera work by Max Stussy, teleprompting by Elisa Verley, and digital shorts by Ariana Longley. Production support from Jonathan Hallowell and TVO's Digital Media Services team. Laurie Few is the executive producer of Digital. John Ferry is Vice President, Programming and Content. Thanks so much for listening.